Uh, it's I'll try to summarize the results and in a very non-technical way, because this paper is actually quite technical in terms of its nutritional content and also econometric methodology. So we know that in many developing countries, problems of sanitations are really quite complex and vast, and uh, you know, and people like Nevin Scrimshaw had made this point in a paper, in a well-known paper in 1959, that nutrient loss due to various infections leads to severe malnutrition. And this is a case, especially in countries like India, where sanitation is really quite poor for most of the populations. Now, the issue really is that you need a long-term longitudinal study if you want to model or these interrelationships, because the relationship could be running in either direction. So that's where econometrics comes in, and so you need to develop some sort of a comprehensive framework. The main focus of this paper, and the fact that it's published in Journal of Nutrition, which has been publishing all these papers about the first 1,000 days, and Gates Foundation is putting in a lot of money in this, and everybody is latched onto this idea that we need to intervene in the first 1,000 days, otherwise these children will be put on a lower growth trajectory. So what is the critical window for interventions? Now, this notion or this paradigm of first 1,000 days is really a bit strange, because it actually contradicts quite a lot of the previous literature. People like James Tanner, Fetus into Man, a classic book that he wrote, and I'll come back to that in a minute. So we know that intakes of protein and micronutrients are very important for children's physical growth and sicknesses. And the fact is that absorption rates of nutrients like especially iron and calcium tend to be low because of the presence of phytates in grains. And so, for example, rice has a fair amount of iron, but it is chelated in the gut by phytates, and so it doesn't get absorbed. And of course, you have this food contamination problem due to poor hygiene, and that also exacerbates nutrient loss. And so these things have to be taken into account in understanding physical growth of children. So the critical thing in some sense is that if you really want to intervene, and we think we know, we have good science, then we should know if you tell me if a child is 8 years old, what sort of a intervention would the child need? Well, the fact is that it's very difficult to match children's nutritional requirements with their intakes, because the science is complex. And in fact, this whole idea of first 1,000 days is very simple. It's very cute. You can just intervene and move on. But the fact is that most of the food is being consumed by these children in much later years. What is more, this first 1,000 days paradigm, is it actually ignores quite a lot of aspects, such as children are going to be sick in later years, consuming contaminated water, contaminated food, and there's this issue of growth spurts, which was emphasized by Tanner. In fact, it was Count Montbéliard in France in the 18th century who kept the height of his son from birth to 20 years on a weekly basis. And you can see where these growth spurts are taking place and so on. So all that literature has somehow been replaced by this strange paradigm of first 1,000 days. And I was at the FASEB meetings in San Diego, and where all these nutritionists are saying the first 1,000 days, and I was trying to say it's really not true. Now, a good counterexample is the Dutch school milk programs. The Nazis had cut off a few Dutch villages, and the women faced, these infants faced intrauterine growth retardation. They were very small in size. The Dutch government went into overdrive. They came out with this program of M brigadiers. So if the parents could certify that you were drinking about 5 glasses of milk a day, you became an M brigadier. And so if you were an M brigadier, you got free passes to the zoo. And everybody, when they gave all the school milk, they had this kind of slogans: milk is good for everyone. And so these children were drinking 5 glasses of milk for a very long time, 25 years. And now, of course, the Dutch male height is about 6 feet 1 inch, and the female height is 5 feet 8 inches. And it's now showing a decline because these programs were discontinued in 1980. So this whole idea, that these Dutch children never received any kind of intervention in the early years, and in fact, they were over 6 or 7 years old, but then they were drinking all these milks. And a lot of economists in Holland, I mean, Manny and I would know, they're all they were all brigadiers, 6 feet 6 inches. And when I wrote to them that your Dutch height is falling, they said, "Thank God," because you can't fit into your beds, you can't fit into showers in Paris hotels, and and there's no advantage on cognitive function. So Robert Vogel, who got the Nobel Prize, in 1993, and he passed away in 2013, he really admired the Dutch population because he himself was 5 feet 3 inches. And I tried to convince him there was no benefit on cognitive function, but he won't listen. He just said, "Do you know Ajax, when he rolled that rock, Ajax was 4 feet 8 inches. And now you see all these movies, these tall guys. Come on, this is the biggest thing that has happened to mankind." But look, it's not. The point I'm trying to make here is that it contradicts the whole first 1,000 days paradigm. And the ironic thing is that even the Dutch nutritionists don't actually know why their population is so tall. In fact, they're looking for some polymorphisms of various genes. And it's completely strange because it's obvious how the Dutch population became so tall. They were one of the taller populations in Northern Europe. Anyway, so the point is that growth spurts around puberty are affected by all kinds of hormones and so on, and also the intakes of protein and micronutrients. And what is kind of a bit dangerous in this biomedical field, especially in the nutritional sciences, is that they're looking at correlations. So if you look at simple correlations between height at 2 years and height at 21 years, those correlations are high, and they interpret that as a sign of inflexibility of some kind. Now, if you're an econometrician, you know that these people have really no understanding of what they're estimating, because the height at 2 years is going to be affected by some underlying genetic factors that are correlated with the error term, and so you're going to get these upward biases. So the point I've tried to make in this paper is very lucky, after 7 revisions, the Journal of Nutrition published it, because it contradicts everything, maybe 100 papers they've published previously and maybe another 1,000 that they'll publish in the next 10 years. So the point is that, we have to have a much more rigorous analysis. Now, the Cebu Longitudinal Health and Nutrition Survey is a very long-running survey between 83 and 22 years here, and it covers over 3,000 children at birth, and then between 0 to 2 years, and then in adolescence. And so we have in total 19 survey rounds of data on the same child. Now that's pretty unique, and of course the fact is Philippines is a very important country since Manny is here, and it's a unique, rich data set, and so I think it's really worth analyzing these data. And in fact, Linda Adair was the principal investigator, and she's published some papers initially saying there was catch-up growth in adolescence, but now saying there is no catch-up growth. So, the same data, there's different sets of conclusions 10 years apart. And I think this is one of the problems with the biomedical literature and sciences, because there's too much emphasis on numbers of papers. And so you can write 10 papers, but if 5 of them are contradicting each other or whatever, it is really not much point. So I've tried to put together one coherent longitudinal study and a story or whatever, the description based on that. So the first survey took place during pregnancy, the second survey after birth. Then you have 12 bi-monthly observations between 2 and 24 months, and then you have these follow-up surveys when the children were 8, 10, 15, 19, and 22 years. So there's a lot of information here, and I think you'll have to allow me maybe 25 minutes. You can interrupt me if you like. The thing is that, maternal food intakes were assessed by 24-hour recalls, and so were infants' food intakes were also assessed, and their birth weights and birth lengths are measured, then their heights and weights, or lengths and weights, are measured between 2 and 24 months. And, there are all kinds of demographic variables like household size, socioeconomic index, and so on. What is more is that the morbidity levels were measured very, there's a lot of information, and nobody, despite all the funds that have gone in this survey, has actually ever looked at the morbidity data, and it is actually complicated to process it. So, I'm also an expert Fortran programmer, and, I had to extract all these variables. So, for example, for child morbidity, we have one index which is based on 6 symptoms in the previous 24 hours. We have a second index which is based on 7 symptoms in the past week, and then there's a diarrhea index. Diarrhea entails a fair amount of nutrient loss, and clearly is important to take into account. Now, there are also data on immunizations, and nutritionists don't think of immunizations as a part of their intervention, but obviously immunizations are very important. They prevent sicknesses, nutrient loss, the children's appetite for food is not suppressed, and so on. So, clearly that's another important consideration. Then we have data on heights and weights of the children at the age of 8, 10, 15, 19, and 22 years. We also have 24-hour recall data for their food intakes at 10, 15, and 19 years. And we can now sort of, develop comprehensive models, and I'm just going to quickly run through them. So birth length, it depends on gender, birth order, and number of persons in the household, socioeconomic index, mother's education, mother's height, mother's weight, and also mother's energy intake, per day, and so on. Similarly, the height during the period 2 to 24 months depends on similar sort of variables, and there are all kinds of things in here, including all their children's sicknesses and the children's diet quality reflected in the intake of the protein to the energy, and also calcium to their energy intakes. So
can you say a little bit more about what is an energy intake for those?
I'll just show it to you. So because they're breastfed too. So this is weaning energy intake, and I'll just show you this descriptive statistics. Then there's a model for the heights between age 8 and 19 years. And again, protein and calcium intakes are included. These are dynamic models, so height in the current time period depends, for example, height in the past time period. And so, it's gradually evolving over time. And then there are these models, which is actually quite a technical topic, but, you cannot include height at age 2 years just as an ordinary regressor when you explain height at 22 years or 21 years. And so you need to allow for some correlation between the errors. So you can use instrumental variables, but you can also use maximum likelihood estimates for dynamic models with 2 time observations. And you can test whether or not height at age 2 is actually correlated with the errors. Now, and this is a random effects model, so there's a child-specific random effect, and it's the model is estimated using maximum likelihood. So here's Manu's question. So let's see now. We have about 47% are girls. The birth order is quite large, quite high actually in the Cebu region, because this is 1983. Number in the households is about 5. The socioeconomic index, of course, is based on different things. Now, mother's highest grade. Now, mother's sickness is also controlled for, not only at birth, 1 year and 2 years, and then mother's heights and mother's weight are measured actually over time. Now, mother's energy intakes, these are kcals. Now, children's energy intakes will be at in a minute. So children's sicknesses are here, and this is again the index of the sicknesses, the morbidity index, but I'm just trying to find the children's. Oh, here they are. So children also suffer from diarrhea, so we know that birth, 1 year, 2 years, and we have immunization in the first 2 years. Actually, about 60% of the children do not receive full immunization, so they are kind of at par with the data like NFHS3 in India, DLHS3, and so on. Now, children's heights are measured at every time point. Now, children's energy intakes. So at 1 year, now, of course, there are, we measure the energy intakes from the age of about 4 months. And the estimate from the breast milk plus the weaning. And so children's energy intake is about 434 kcals at 1 year, actually excluding breast milk. Sorry about that. And then at two years, it's about 727. Then there's children's protein intake and children's calcium intake and their beta carotene intake. So we have these 24-hour recalls, and we can estimate what their intakes are. And again, we have these figures when the children are 8 years, 10 years, 15 years, and 19 years. And you can see how their weights are gradually increasing over time. The energy intakes are increasing, but of course there's no breastfeeding involved anymore. Protein intakes are reasonable, and the calcium intakes too are reasonable. And beta carotene intake is generally measured with a high variation, because food prices, especially of fruits and vegetables, are quite seasonal in these regions. So let me try to summarize some results, and then we can discuss whatever you want in more detail. So there's a model for birth length and weight, and really all we want to talk about here is, of course, birth order is important, and mother's height's grade is important for children's length, and it's not significant here for weight. Mother's anthropometric variables are certainly very highly associated with infant's length. So, this is for mother's height, mother's weight, and mother's energy intake. In fact, mother's energy intake from fat was also a significant predictor in some of these models. And so, generally speaking, we are lucky to have food intakes of the mothers and see that that affects the quality of breast milk. This is one of the biggest problems in India. The reason why there's so much growth failure in India is that these undernourished mothers, especially in these northern states, without adequate, with poor diet quality, their breast milk is mainly very, very watery, and it doesn't supply adequate amount of fat and micronutrients. So, these are really important practical issues. Now, for children's, so Philippines is just a good example because we have such an elaborate data set. But we can answer quite a lot of these questions. So, for example, Arvind Panagaria claimed that we need different growth standards for Indian children, and there are a lot of sicknesses. In fact, Mike Golden had written a paper in 1994 in European Journal of Clinical Nutrition, making the point that even if you intervene in developing countries, you're not going to achieve optimal growth because of the environmental factors. So again, that's the sort of things that I'm emphasizing in this paper. So we look at the weight and height and weights of the children between 2 and 24 months. You can see that mother's BMI is again a significant predictor, and mother's energy intake too, because that's really affecting the quality or the fat content, especially or the energy content of breast milk. And mother's sicknesses are negatively associated with the heights and weights of these young children between the age of 2 months to 22 to 24 months. Now, children who are immunized tend to grow more rapidly or are taller and heavier. Clearly, immunizations are very important. And children who are sick, there's the morbidity indices 1 and 2. They're negatively associated with height and weight, and diarrhea index as well. Now, children's protein to energy intake ratio. Now, this is a bit complicated issue here because, we do not know how physically active these children are, so you don't know what their energy expenditures are. So, in some sense, when you convert protein intakes to the ratio of energy intakes, you've actually taken that problem into account. At least for weight, you can see that this is an indicator of diet quality. I have another paper in the World Bank Research Observer that when Manny was the editor in 2015, again making the point that the ratio of protein to energy intake is actually a good indicator of diet quality. Similarly for calcium to energy intake, and these are all statistically significant. Now, of course, you could have, since you have a model for children's weight, you could actually include their height as well, because height determines their skeletal size and so on. And so there are two different models here, and there are these statistical tests to see if there's correlation between the errors and the random effect, between the errors and the errors that contain the random effects and some of the explanatory variables. Now, there's a model for children's sicknesses. So there's morbidity index 1 and diarrhea index. In fact, it's very similar, the indices 1 and 2. And you can see that, in children with large household size, they tend to be more sick. If mothers are better educated, they tend to be less sick. Children's and mothers' morbidity indices are positively associated, not surprisingly. Now, the piped water was not statistically significant, but they asked children about the general household hygiene conditions, and you can see the better the hygiene, the lower the sicknesses, at least the morbidity index 1 and actually 2 as well, but not the diarrhea index. Now, children's heights are, of course, associated with morbidity index. Now, the causality could run, especially in the weight model, in the reverse direction, and so that's addressed also in the paper. But I think quite interestingly, we see that children's beta carotene intakes to their energy intake is again significant predictor, negatively associated with both children's morbidity index 1 and diarrhea index 1. Now, it's true that we know from a biological point of view that if the diet is high in vitamin A or beta carotene, which is a precursor to vitamin A, and also vitamin C, it enhances the immunity systems. But to show these relationship in a population level is actually quite complicated. And as I can assure you that this was very complicated programming, because some components of the morbidity were not really compiled very for there were a lot of missing observations, and you have to treat the data in some sensible way and so on. So that gives you some idea of their sicknesses. And then there is a model for children's development during adolescence. Now, the point about this first 1,000 days is that, can we really say that children's intakes in the early years are significant predictors, but not in later years? Now of energy, of protein and calcium intakes. So in some sense, you're looking at the issues of catch-up growth, and people like Tanner emphasize catch-up growth, and Tanner wrote this very important book, Fetus into Man, and there are all kinds of information in there. But somehow the nutritionists have ignored all that, and they've started just emphasizing the first 1,000 days. And it's bizarre, because how much food can you feed these little infants in the first 1,000 days? Very little. It's really a lot of the growth action is taking place much later on. Of course, the first 1,000 days are important, but the issue is you cannot exclusively focus on first 1,000 days. So here you see, I'll just quickly go through the main results, which is that if you look at the protein intakes, they're significantly associated with children's heights and children's weights. This is in adolescence. And children's calcium intake is a statistically significant predictor of their heights in these dynamic models. Now, this predicting of height at 2 years from using height at 2 years is really a very complicated exercise. And it's for some reason Ray Martorell popularized this, that there's no catch-up growth, and all that matters is the height at 2 years. But you can see the problem is that there are 4 specifications here. So in specification 1, the height at 2 years is treated as a regular explanatory variable which is not correlated with the errors, and it has a very significant large coefficient. But we know that height at age 2 is likely to be correlated with the error terms. If you use instrumental variables, this coefficient falls and is not statistically significant. If you do a test for exogeneity for the height at age 2, this is a chi-square test, and it will reject the null hypothesis. So basically, the results are saying you must treat height at age 2 as correlated with the errors. Now, maybe this is not the best model, and so there is yet another model, which is specification 3 and 4. And in specification 3 and 4, you take the calcium intakes and protein intakes at age 2 years and 22 years, and you can see that protein intakes are significant, especially in specification 4, where the errors are assumed to be correlated with the heights at age 2 years. And similarly, if you look at the calcium intakes, they are statistically significant in the model for children's height here.
Sorry, can you just clarify? So protein and calcium intake at age 2 correlated with heights at age 22, or
no, it's
retrospective? Or?
No, it's a bit more complicated than that. It's a time varying model. So you've got, let's say, height at age 2, you've got protein intake at age 2. Yes. You've got height at age 22, and you've got protein intakes during adolescence. So it's a time varying variable. And the issue is, can we treat the previous value as uncorrelated with the error term? And the answer is no again, because if you look here, the chi-square test again rejects the null hypothesis. The point I'm trying to make is that I don't know how they got this paradigm in the first place, because you really have to be a methodologist to come up with something of this kind, because it's really a statistical issue. That how do I predict? If you look at simple correlations, they're very high, but we know that there's so many genetic factors underlying height, and apart from all the dietary intakes information that is missing all through the growth period, how can you actually make a claim that we should focus only on the first 1,000 days? It makes very little sense. So the point I'm here is, in fact, some of the reviewers of the Journal of Nutrition were saying, just turn this paper down, because this is not nutrition. This is, this is much more epidemiologic literature analysis. But the fact is that if you make a claim that first 1,000 days matter and nothing else matters, then you need to be able to test it. And the only way to test it methodologically is by doing all this kind of exercise. So generally, let me try to wind up. And so we have a lot of, we need fair number of nutritional and environmental interventions for enhancing physical growth and reducing sicknesses. Now, we saw that the higher intakes of protein and calcium during early years in adolescence are likely to enhance physical growth. Higher beta-carotene intakes reduce sicknesses. Immunisations were negatively associated with sicknesses. So it's not a simple process that if you want to increase heights in Philippines, you will have to have a much longer term perspective. Now, again, I think it's quite misleading to look at these positive correlations or associations between height at 2 years and adult height as showing that early interventions are the way to go. I mean, it's true that you want to intervene as early as possible, but most of the intervention, especially in terms of food policy. Now, there's a bit of a tension here in the sense that nutritionists are doing these short-term randomized controlled trials, and they leave after a year, and they report whether they found a significant effect or not. And as a result, there can be a tendency of overdosing children. So we saw the Pemba study in Zanzibar where they fed 12.5 milligrams of iron to these infants. It's a malaria endemic area. Many infants died as a result of the malaria parasite reproducing at a higher rate given all that iron. So, the point I've been trying to make in this paper and in the World Bank Research Observer is that we really want to emphasize food policies because, it's harmless to improve diet quality. There are no adverse effects. Now, it is true that the heights of the children may not go up rapidly like they went up in Holland. But, the fact is, given the limited resources, at least there are no risks involved, and you improve the diet quality over generations gradually. Maybe these people will increase, the body size will increase, like the Japanese, for example. It took a few generations, but the average heights have been increasing. So essentially then, if you want to take a long-term perspective now, from the point of view of 3IE, I know the evaluation is very important and it's fair enough. I mean, if you have a study running only 1 year, 2 years, 3 years, you want to see what the impact was. But I think there's another element here because a lot of these interventions have been successful in developed countries. And this is the whole point about randomized controlled trials. You're testing a very specific hypothesis, and if the biological relationship is well understood, there is no need to run a randomized controlled trial because you know a priori what the effect is. For example, of deworming, the effect will be on hemoglobin and ferritin concentration. But you get all these economists claiming how deworming is increasing cognitive function, how Africa will grow by 10% in the Kremer and Ted Miguel. And clearly in Africa the problem is that many of the parents are dying of HIV/AIDS. In fact, children are not even going to school; they're supporting their parents. So what I'm trying to say here is that we really want very long-term food and health policies, and they give us a good idea of. Or they are the very safest sort of mechanisms to go through. But of course, if you have evaluation, you really, even the difference in difference estimator, it's really not realized by most of these people who've been estimating these models that if you had multiple time observations, the difference in difference estimator, actually the efficient version would be the fixed effects estimator because the variance covariance matrix is not the identity matrix. But what they do is just look at 2 time points, see if the growth increased, and talk about causality. Now again, causality is a very complex issue. Philosophers like Wittgenstein, thought that causality is just an illusion. But if you read people like Vernon Heisenberg in physics, you'll see that causality is very hard to determine even in physics. And it was John von Neumann who wrote a paper in 1961, which I'm sure nobody's ever heard of, but which made the point that is not much point looking at causality in biological systems or social sciences. We really want to see how the system is evolving over time. And so this whole idea that we'll do a randomized control trial, we'll learn about causality, it'll lead to efficacious policies and so on, it's all very simplistic because you have to be very careful what your randomized control trial is doing and why are you doing it in the first place and what are the limitations. But as I said again, I'm not trying to discount evaluation. Evaluation is important, but I think one needs to take a long-term perspective. And if we know that children are going to grow in next 20 years, then if they didn't show good growth within the next 2 years, we can still be optimistic. There may be some other biomarkers that have increased and so on. So that's really all what I wanted to say.